Welcome back to the No Shame Podcast. I'm Fran and this is
Dan.
And we are here covering episode 3, right? 3, that's crazy.
Wild.
Yeah. So on our prior episode, we talked about triage and kind of what that looks like for a pregnant person. And today we're going to cover the experience of actually being admitted to have your baby and what that looks like for you.
So we're basically talking about triage, and then you're walking your way over into the labor room. Mm-hmm. And sometimes they're not different rooms, but they mean different things for what actually happens behind the scenes. You know, one thing I always think that's important and just to notice, so like let's say you get admitted, right? You come in and you watch the last episode, we did all of our workup and you're like da-da-da-da, you get admitted. So that means that the doctors at the hospital, whoever saw you, or the PAs or the NPs, whoever they're, the providers, they're putting in their orders and saying, hey, welcome to the hospital kind of a thing. And the nurses are figuring out who's going to be your nurse. Mm-hmm. You get your nurse for that whole process, for her shift or his shift, right? You get that person because they're going to be taking care of you that whole time. So it's actually a lot of stuff happening behind the scenes to make sure that you have the appropriate care.
Mm-hmm. Yep. And so whomever you get is usually really picked. The charge nurse will assign a nurse based on your personality to the best they can for the little bit that we know you. Mm-hmm. And then you have someone that's going to be by your side, checking your vitals, checking in on you, supporting you, doing all this wonderful stuff, even doing a lot of labor movements with you to help try to facilitate your labor process, all while like just we're behind the scenes kind of making sure you're safe and your baby's safe.
Yeah, so I mean, let's actually talk about who the hell is there.
True.
Right? True. So like you get admitted. Is your doctor there right now?
Not always.
Not always.
Not always.
Unless you're like that 9.5 centimeters that we spoke about, right? That fake, fully dilated, whatever. So like you're not just having a baby like that moment.
Yeah.
But to be honest, there's so many other people that are there that are so important to your care that you might not even know.
True.
Right? So we spoke about the person that saw you in triage. So any of the providers that saw you. So you finally met them. Mm-hmm. You saw the triage nurse. Yep. You met her or him. And then they're probably moving on from you.
Yeah.
Because they're staying with triage. That's their job.
Yes.
For that shift. Yeah. They do everything. And you're getting assigned your own labor nurse. Mm-hmm. Just so you know, you also get a nurse for your baby when that baby's born. And you might not know it at that moment, and no one knows it at that moment who that nurse is, because there might be so many babies delivered one in between, right? But that's why when you see people walking into the room as you get closer to delivery, they all have a specific role.
Yes.
So one of those people one of those persons, whatever, is the baby nurse. Great, God bless. But labor and delivery, right? Who are the providers that are there? Who knows that you exist? Actually, right? Yes. I feel like that's a way of putting it. Who knows that you exist?
Great way to put it.
All right.
So typically, in most institutions, you'll have a resident team or an ACP, which we call Advanced Clinical Providers, which is your PA&P team.
Right.
Sometimes you're lucky enough to have both, but if not, it's one or the other. And those are the people that will examine your cervix, that will check on you, that will tell you the plan, tell you any updates on your status, and just kind of keep you abreast of everything that's going on. And then they're the middle person between you and your doctor. So they'll do what they got to do. They'll check you, they'll call your doctor, they'll get the plan from your doctor, they'll impart that plan to your nurse and you, and then hopefully things will be all in alignment. Now, we do have to talk about birth plans.
Oh,
birth plans.
I love me a good birth plan.
I love to make fun of the ridiculous birth plans.
But I love actually talking about birth plans in the office.
Where you should be,
you should be having that amazing discussion. Yes. And birth plans, I think, are honestly important because
critically important.
They bring up stuff in the office. This is not a thing that I should be shocked that you like want to eat your placenta or whatever it is. Like, I don't need that. This is why you see us in the office for 8.5 months before then.
Yes.
So birth plans, let's talk about them.
Okay, so there's like a million templates for these online, right? I will tell you, most of them are completely reasonable.
Absolutely.
In fact, we do all this stuff already. So like ambulation or like freedom to move around. We want you to do that. We don't want you laying in a bed not moving to get a blood clot.
Correct.
Wouldn't help anybody.
If you are free to move around, why aren't you moving around, right? If we're sending you home, it's not because you're not ready to be here, but because we want you to move around in your own space.
Right.
So that's super important. But let's say because you broke your water and you're staying at the hospital, you know, just because you have straps on or we have things that can wirelessly monitor you, that doesn't mean you should be laying in bed.
Right.
I wouldn't.
No starfish. We don't want a starfish.
Correct.
We want you just stretching and moving
Booming,
and really laboring
moving.
yourself and feeling your body.
Correct.
So there's so many things on that birth plan. Like I've seen, like, I don't want an IV. Listen, I get it. No one likes an IV. I didn't like 3 of mine. But the point is that if you're trusting us to take care of you, you have to let us take care of you.
Yeah, and the IV is doesn't mean that you're getting medication to induce your labor.
Or fluids or anything.
At all.
You just have an access to an vein that, God forbid, something goes haywire. I don't have to start sticking you when
it is literally
shit is hitting the fan.
It's survival.
It is survival.
We can help you so much.
It sounds so silly, but it's survival. And
absolutely.
Like let that be the least of your worries
Absolutely.
for the process, right?
And the nurses do honestly a fantastic job. They try to not to put it here, right? Like this area,
you
because
wanna
you're
hold your
always
baby.
bending, you're moving stuff.
your leg.
So they're always trying to maybe do it on your here or here, places that are not inhibiting your movements.
Yeah.
You know, so that we're cognizant of those things. And putting an IV does not mean you're getting induced. It just means that, God forbid, there's a situation that's like, yo, we need to move. We have that access to help you with medication if needed.
Right. And then other things I've seen, like, I don't want you to break my water. I want it to happen naturally. All right, cool. To the best we can. We'll let that happen.
And I think that, you know, when it comes to the management of labor and augmentation of labor, meaning that how we can help you get to that point, you know, I think a lot of that stems from your relationship with your physician before you even get to the hospital. You know, I always say, look, in my practice, we have similar mentalities. I really do think so, but we have different personalities, and that's just what it is. And some are crazy, some are calm, some are dad, some are all in between, right? Yeah. And we're just all different, right? But we have the same mentality of we want healthy mom, healthy baby.
Right.
That's what it is. We don't have dinner plans when we're on call. We're not getting our nails done because of this time. If I'm on call from 8 in the morning, Wednesday, till 8 in the morning, Thursday, I have no plans. I'm not picking up my kids. My wife knows. My kids know that I may be working, maybe not, whatever it is, but I am focused on the hospital. That's the beauty of having a lot of doctors at 100%. Yeah. So therefore, whatever that is, you know, we make that plan together. So basically what I'm trying to say is that you want to establish that trust and relationship in the office. So when it comes to the hospital and things are happening, it doesn't mean you shouldn't advocate for yourself, but it just means that you should be having that discussion. And I think good physicians, good providers, anybody are not saying, hey, you need this, but say, hey, this is what's happening, and these are the things that we can help you with. Yeah. And it's just how you present information. Yeah. And for the residents, for the PAs, for the NPs, for the physicians, anyone that's taking care of you, understand that a lot of these people have no idea what we're doing, why we're doing it. And they get information maybe not from the best sources, but it doesn't matter. We have to give them the information the way they want to perceive and receive information. And I think that's super important.
Mm-hmm. And you should feel comfortable as a patient, as a human, as a mother, to advocate for yourself and just say, hey, why am I getting that? Right. What's the point of that? Because we know the point. You maybe
Correct.
Don't, and we maybe have that disconnect where we don't know that you don't know, right? We assume you know that you need an IV because if you suddenly have high blood pressures that are dangerous and may make you seize or stroke, we need to give you IV medications.
Whatever.
Or let's just say, God forbid, you start to hemorrhage from an unknown issue and we need to give you blood. Yeah. You need to have an IV so we can take care of that. So there's a lot of
seconds
stuff.
matter.
And seconds matter.
It's not 30 minutes later.
No, you'll be dead.
We have protocols set up that's minute, second by second of intervention. And we don't want to get into that because the goal is for you to have that we talked about, just like the baby, plop, you see on TV, which never happens. We want you to have that.
We want you to have that experience that you have in your brain, this beautiful birth experience. Correct. And like your wedding, if you've had one, or like a big event, you plan to the most minute details. But once you do that, shit goes awry. So you have to be able to kind of pivot and know what's going to happen. So like one of those things that can happen is that the baby's heart rate will change in labor, especially as you progress. And so what may happen is that we might want to put a monitor on you, your baby actually, to track that baby's heartbeat. And so,
because especially like imagine you're moving around, you're doing stuff, and there's stuff that's like, oh, the baby's heartbeat is changing, and you're going to see people walk in, and we want to make sure everything's good. We're moving you around, but we can't know as well.
But we can.
Oh my God. So
with this internal scalp electrode. So
better known as the ISC.
The ISC or FSC, depending on where you live.
Correct.
So this guy is oh shit, sorry dude. Gotta chill out on those drinks. This is a flexible piece of plastic, and inside is a cable connected to a tiny little needle. So this tiny little needle screws, I know it sounds horrible, but bear with me, gently attaches, let's say, onto the baby's head.
I've had this screwed onto my head. It's not gentle. I don't care what you say.
As an infant?
No, as a resident.
You feel it though.
Oh, I felt it.
Danny. The baby doesn't feel it.
It's not,
okay. And quite honestly, we don't do this for fun. If we're doing this, there's a reason, and like everything else that we do, there's a risk versus benefit. It's not
gonna affect your baby in any way. That's not the point of it.
This literally, I could screw it right now, as I'm doing, into my finger.
Into your finger.
Ow.
Yeah.
But the point is that it goes on, and no matter what position you're in, no matter how you want to labor, we hear the baby's heartbeat directly.
Right. And so like that thing gets connected to your baby's head, because that's the only thing that we feel when we do a vaginal exam.
Yep.
Hopefully, because your baby's head down, right? And then we put a sticker onto your thigh.
Yep. And
that basically creates kind of like a monitor that's like an EKG. And then we could directly assess your baby's heartbeat. So you could be literally standing up, doing jumping jacks, doesn't matter, even though that can kind of screwed up a little bit, but whatever. But we can assess your baby's heartbeat directly. And that's like an awesome tool to have to really say, hey, to assess how the kiddo is doing.
Correct.
You know, I got to tell you, back in the days, before my time.
So my time.
No, like before.
Before my time?
So one way they used to assess babies.
Oh.
Do you know what?
The fetal pH?
Yeah.
Yeah.
You did that?
No.
Oh, I was about to say, there's no friggin' way.
No.
They used to put a speculum, that little fun toy that a friend was holding before. Yeah. And they went in there and literally like stabbed your baby in the head and got a little bit of blood, and to assess to how the baby's acid-base status is. Yeah, we don't do that anymore.
We don't do that any longer. Although I heard a rumor that might be coming back.
Is it really? I mean, it is a direct way to test for fetal well-being.
Let's be real. And the truth is, and you guys need to hear this, that monitor we're using,
it's not perfect.
It's not perfect.
Nowhere
it can
close.
tell us if a baby is good or horrible, but there's a lot of
everything
gray.
In between,
it's very difficult to interpret, and gray. It is really unpredictable. And so we do our best because we have the tools, but truly it is not a perfect system. So, take it with a very heavy hand of salt.
Yeah, I mean, we're not a perfect system as a whole, and we all know that. Anyone that thinks that they know everything is also, like I said before, it's not
run from those people.
You know, we've definitely have significantly improved in maternal morbidity and mortality over centuries, but we have so much more to improve on, especially with racial disparities, and we all know about that, and we get taught about that. And our goals are always to try to fix those things. So heart rate monitors aren't perfect. We definitely know that, but they do tell us some information that can be super crucial to your baby.
Yeah.
So for example, if your baby's heartbeat is great and then all of a sudden it just drops and it never comes back up, that's bad, right? So we have tools, especially let's say you're pushing. And like when
let me cut you off.
Okay, go ahead.
Before we get to the pushing part, let's talk about if that heart rate comes down and up and down and up and down and up. Then we have some other tools in our toolkit that Dr. Kaitov has generously provided for us. Something called an IUPC, which stands for intrauterine pressure catheter. And this is how we measure your contraction strength from the inside of the uterus.
And it's like a twofold device. It actually,
Go for it.
It helps us.
Show us, Dan. Let's see what it looks like.
It doesn't look like anything fancy, but it's like a long wire. And on this edge, it's connected to something on a computer, but it doesn't matter. But same thing, plastic thing here. You don't see it, but this is the plastic part that separates. And this plastic thing, you go, and with the other device, normally the providers would go in with hand in the vagina. Unfortunately, that's just the way it is.
How we get there.
And they kind of feed it in there, and they feed this, well, I gotta eventually feed, there you go.
There you go.
And they feed this into the uterus.
What you don't see super well, though, is that all along here are these really cute little holes, right? And so once it wraps around the uterus and your baby, we can, A, monitor the strength of the contraction.
Which you can't do from the outside.
Correct.
We know when you're having a contraction from the outside, but not how strong you're having the contractions.
Right. But this also now, we hook this up to a saline bag or lactated ringers or whatever your nurse has or whatever your doctor wants. Doesn't matter.
Doesn't matter.
The point is that we can run fluid and then this becomes like a little shower. It's a baby shower. I know, he can't stand me.
I can't do this.
But the point is that it helps alleviate some of the stressors that could be causing drops in the heart rate, primarily.
So, for example, let's say you broke your water, right? And the baby decides to be a schmuck, like my second child was. And the cord, right? There's a cord inside, and that feeds the baby all the oxygen right here. And the kiddo lost all his blood, and it's just like laying on the cord.
Not blood, fluid.
Fluid, whatever. It's just laying on the cord.
Lost all his fluid.
Right, lost all his fluid. And it's laying on the cord, and it's actually suppressing its own freaking oxygen. It's laying on the cord, and mom cannot feed the baby with oxygen. So what we do is like, okay, hey mom, listen, we're seeing this stuff on the monitor. Like we go in there and we're like, let's try to flip you around first. Let's try to move you. Let's get you up. Let's get you on your side. Let's rotate you on all fours. Anything. Who cares? Whatever position works. We'll take it. It doesn't matter what it is. So we'll do that. Let's say that's not working and we know that she broke her water. We're like, hey, listen, another thing we could try is like, hey, let's put this thing in and we could give the baby some fluid. And basically, instead of it swimming in a pool that's super shallow because you lost the fluid, let's swim in a pool that's full. So therefore, the kiddo floats again. So when it's laying on the cord and it has fluid back, it kind of opens up and then the cord releases itself and keeps floating. And therefore, that oxygen flowing through the cord into the kiddo, through the belly button, is actually doing what it needs to be doing.
Correct.
And that works pretty freaking well.
Yeah.
And it's one of our biggest tools for certain kind of like heart rate changes that we have to help fix it to get you closer to a vaginal delivery.
Yes.
Right.
Now, we can talk about induction all day long. There's a million different ways to do it.
Right.
So let's just say a lot of patients don't come in labor. They come in with a medical issue and they need to be induced.
Correct.
Or their water broke but they're not in labor, so you need to be induced. We're not here to give you the rundown of all the meds because there are so many flavors of things and so many approaches. But speak to your doctor or your midwife about what they're comfortable using and why. Because there are certain things that are recommended in situations like if your baby is a little bit smaller, there might be an approach you might take that's different than if a baby is an average size infant, fetus, whatever. And then just kind of like the studies that are coming out are suggesting certain ways to do things versus historically it was more of an art form. Obstetrics was an art form.
I think it's still a dance.
It still is a dance.
It's a dance.
But there is literature that's starting to suggest.
I think some patients think I'm super freaking weird for saying this sometimes.
It's a dance.
It's a dance.
It's a dance. It's a dance.
And I always say like, so I've had people who are like just coming in and very favorable to have an induction, whatever it is. And I'm like, listen, it's a dance. We have to stimulate the contractions. And then once you're booming and grooving, then we break your water.
Or you break your own.
Or break your own, whatever works. And then we have a baby. And when that works, it's a dance.
Beautiful. It is.
But it's not the same for everyone.
No.
And this is me talking about like the ideal, like whatever. It's not one all be all.
No.
There's so many, like Fran said, there's so many variations in this, and we can't teach you what is perfect for you.
Correct.
That's where you hope that the people that you are seeing can really help guide you in those moments, because, you know, people say like, okay, there's 3 meds, 1 med, baby, right? I'm like, well, that's very cute. That's like, okay, whoop-de-doo, but like, that's not the way the stuff works.
Because if I check you and I'm like, ooh, this person would do really well with this and this and this.
Right.
Or I check this other patient and I'm like, ugh.
Right.
She's gonna need a longer induction because she's not dilated at all, not thinning out at all. Like, we need to do a slower approach.
Right.
Or this baby's really little. We should be gentler than we would be with an
Like
average
little,
size
and
kid.
little not in a good way. Like,
Right.
let's say little
like
less than the 10th percentile
correct,
way.
where we consider that actually a reason to induce you because the placenta's not doing its job. So there are so many facets to that. So we're gonna let that lie.
That's a discussion between you and your physician, and growing a good, healthy relationship
Correct.
between the two, because that requires a lot of expertise
Yeah.
and appreciation.
Yeah. And honestly, if
respect.
we start talking about it, we'll be here for like fucking 6 hours.
No, we'll be
because
here for 4
it's-
years,
yeah,
the length of
no,
a residency.
You'll want to shoot us
This is-
because we will not stop talking
Correct.
about it. So.
Let's talk about the fun stuff.
Cool. So you get to complete, aka fully dilated, aka 10 centimeters, aka
And
you're
I
ready to
get
push.
there from my bed.
Correct. In record time. Blows all the lights. Doesn't get coffee.
Safely,
Morning
driving
breath.
safely.
The whole shit. All right.
I brush my teeth. My wife's a dentist. I brush
That's
my
true.
teeth.
That's
I
true.
brush my teeth.
So he pulls up. Now you're ready to push. There's so many ways this can go. Do not think for a second that just because you're 10 means you're having a vaginal delivery.
Yeah.
Fallacy.
That's actually a big point. Just because you're fully dilated does not mean you're going to have a vaginal delivery. Because even though you made it so far, right? 0 to 10 is
A whole
that's
marathon in
my
itself.
God, let's celebrate that in itself. 10 to delivery, that's
It's a different feat.
It's a different game.
Different feat. It's like you're doing a triathlon. So the first part is getting into labor. Then it's labor to fully. Then it's pushing a baby out of your body. And then after that, it's actually like,
raising the kid for 18 years.
well, I was going to say placenta and recovery, but
Oh,
sure,
sure.
that too.
Okay, fine.
Yes.
That's what
But
I'm
so Dr. Kaitov is one of the few physicians I know that's very skilled in
Somewhat
helping
skilled.
patients out. Now, I've pushed out 3 kids, and the first is always the hardest. That is just typically the rule of thumb, right? Once you get over the first kid, the other is kind of like, poo, poo, poo.
On average.
Not always, but
Not
for the most
always,
part,
but
right?
yes.
But I will tell you that pushing feels great. And everyone thinks I'm crazy.
Hmm.
But the truth is that your body is meant to expulse your baby, right? But you have to know what that feels like, right? So if right now you're looking at me, do a Kegel. You just did it, didn't you? You did it! I know you fucking did it! Okay, so you do a Kegel. Okay, wrong. That is the opposite of what you need to do. When you have to push up,
sucking it in.
yeah. So when you push your baby out, you're gonna push like you're pooping. So this is the biggest question we hear all the
Just-
freaking time.
just fucking
Just
poop.
poop. We don't
Just
care. We don't care.
Like, you're not gonna blow me up like just poop. And you're gonna feel
It feels good.
Right.
It feels good because your body wants to do it. What happens, what I hate, is this thing. And the blood vessels are popping.
Yeah.
And I'm like, no, wrong place. Or they're kicking. They're kicking your, I'm like, why are you kicking me like a kangaroo, bro? Like,
I got chested by one patient.
it's crazy. And you're like, stop, pause. You're wasting your energy.
And we teach, like, we try to discuss and we teach. It's not like we expect you, okay, you're fully dilated, you should know how to push all of a sudden.
Mm-hmm.
You know, that's just not the way it works. And that's where amazing nurses come in to kind of have the discussion, and doulas who are awesome and discussing that with you. And honestly, physicians too.
A lot of us too,
Like,
yeah.
we all come in and we teach you how to push.
Right.
We assess how you're pushing. We check the different positions of how you're pushing.
Yeah.
And we see what's working. So when a lot of people say, don't push on your back, some people push pretty freaking well on their back.
Yeah.
Some people suck. And that's just not the position. Some people on the side, some
Yeah,
people standing up, some, I don't care.
Some hold the towel. It's whatever works for you personally.
It's a dance.
You know, and the problem is that social media will make you feel like a failure any way you fucking do it.
Correct.
They'll tell you you're a failure because you're doing it on your back is the patriarchy wants. Like,
Right.
bro, I have an epidural. I can't stand up.
Right.
I want to push the way I want to push, and it worked, right? Or people are like, I want to push on all fours. Do you know what I hate? pushing on all fours. You know why? Because when your baby is crowning, you are shitting on your baby. This is real talk, no shame. I don't care. You want to do it? That's your dream. Go, girl. I'll support your dream. We'll support your dream.
I'll support your dream.
But it's fucking gross. It is. I'm sorry.
But if you got to do it and it's working, it's working.
But don't do it just because somebody on your TikTok told you to do that, because that is bull.
And trust me, if we're telling you, hey, this is working, just do it this way. I'm not gonna say for all, but I'm gonna say for most, like, hey, it's working. You're doing great. The kiddo's descending. Like, you're doing awesome. Yeah. Let's just keep doing this. And if we got to change, we change.
Yeah.
But I just want to change the narrative of saying that you have to push on, like, if people are like this, you have to push on your back. That's easier for me, and that's it. It's just not that.
And honestly, most people won't. Like, there's this weird myth that, like, it's easier to just go and do a C-section.
No, it's not.
It's fucking not, and I'll tell you why.
And there's a myth that if you do a C-section, you get paid more.
You don't get paid more.
Like, what are we talking about?
No.
But go ahead. What were you saying? Yeah.
The point is, okay, so you're pushing, right? And you've been pushing for 3 hours without an epidural.
Okay.
If it's your first child,
Yeah.
right?
Yep.
4 hours with an epidural if it's your first child. And take away an hour of those if it's your second, third, whatever child.
Right.
You're pushing your heart out. You're doing all the positions. We've got you. We keep changing we're doing you flying cowgirl. We're doing, we're doing all of these cool movements with our
maneuvers and
with our birthing balls.
rotations.
And we're trying everything to get you to have a baby. But there's more than just you in this process, right? So what I learned in PA school, what Dr. Kaitov, Danny has learned in medical school are the P's, right? You have the power, the passenger, and the pelvis, okay? This is really important. I need you guys who've had C-sections who are still resentful of it or feel like you were gypped. I need you to hear something.
Provider.
No. That's not a P. Passenger. This is your baby. Is your baby in the proper position?
Right.
Is it looking in the proper way to optimize your pelvic dimensions to get through it? Right.
Is your baby coming out face presentation? Meaning, is the kid's face coming out first?
Right. Is it compound where an arm is coming first? Is it breech? Is it oblique? Meaning it's not even straight down. It's kind of oblong, like going with an ear first. Is it sunny side up, which is a way harder baby to push out? Almost never kind of first time mommy push out.
Is it asynclitic? Instead of coming like this?
It's coming
crooked.
Like this. Yeah.
That makes a big difference.
So many positions of these little ones, and it's got nothing to do with you.
They're schmucks.
Nothing to do with you. So that's your passenger. Your pelvis. Mm-hmm. Now this is on you, but not something you can control. This is your mom's fault. If you wanted another reason to blame her for shit, your
grandma's amazing. I love grandma.
He's partial to grandma.
Grandma's dope.
Different shaped pelvises open and close differently, right? So if your baby is too big for the opening or the outlet of your pelvis, that's got nothing to do with you, but it is going to impact your ability to have a vaginal delivery.
And sometimes your pelvis was supposed to have a 7-pound kiddo, right? Because that's just what's been happening. But you wanted to marry this NFL football player that's like 7 foot 78 inches. Yeah, man. And you have like a LGA, like a big ass kiddo that's like,
motherfucker like this.
Right. And God bless, might go to the NFL again. Let's go pay off some med school loans, would be dope. But thankfully, we're in a society of like, we are having babies with people outside of our cultural norms, let's just say.
Yeah.
And that's great. That's awesome. But that doesn't mean your pelvis was made for that. And also sometimes you just get gestational diabetes in the pregnancy.
And you get these fucking linebacker babies.
And you have first 4 kids that were 6.5 pounds, and this one's just 10.
No shot. Well, not no
just
shot.
A shot.
But like, it's our like anxiety level is way higher.
Yeah.
But so we talked about your pelvis, your passenger, and then the last is your power, your contraction strength. So you need to have the right push behind it, the right size passenger for your pelvis, and all those things have to align in this beautiful constellation for you to get that baby out of your body.
Yeah.
And so this is why women, 100, 200 years ago died. Like this is why people forget. Like 50 years ago, even now, we're one of the most developed nations with one of the worst, mommy morbidity and mortality, because we're getting lost in the sauce. Like, we're not realizing that there's so many more factors. So keep in mind, if you had a C-section or you needed a C-section, it's not necessarily like you didn't push well enough or your baby was too big. Or it could just be so many factors aligned together.
And it kind of goes back to the no shame thing.
Yeah.
Don't compare yourself to your friends.
Yeah.
Don't compare yourself to what's on TV. Don't compare yourself to anybody. This is your story, but it doesn't have to be everyone else's story. This is your personal story. And if you got a healthy mom and healthy baby out of a C-section, there's nothing wrong with that.
Yeah. Even if you just wanted one because you want one. Now, listen, I don't want to share my personal opinion, but I'm gonna because it's my podcast.
You're
so,
a friend.
But I don't like a primary.
How do you feel? Tell me how you feel.
I don't like a primary elective C-section. It is an abdominal surgery. It is a very common surgery, but it is a invasive abdominal surgery. It is one of the most common. But it is an invasive surgery. We're cutting you open and going through layers of tissue. And I don't love that if there's no real reason.
But it is absolutely
it's your choice.
Your choice.
I'm the most pro-choice bitch on this earth. It's your choice whether you want that or not.
I am the most pro-choice physician helper for you.
Yes. However, we will tell you, though, you need a proper informed consent. What that means is you need to know what you're signing up for.
Yep.
You know, it is true that we're going to take care of your pain the same way we would take care of someone who had a delivery vaginally, but you need to know that it's not the same recovery.
And what that entails in the future. Recovery, future surgeries, future deliveries. There's a lot to it.
All of that.